Hello, I'm Dr. Ajay Gupta. I'm a clinical reader, or you can say associate professor in cardiovascular preventive medicine and also clinical pharmacology. I'm here to talk to you about my recent trials findings, which is called SCRATCH-HTN study. We are also expecting to discuss about hypertension treatment horizons for future. So yes, the SCRATCH-HTN study is a phase 2A double-blind sham-controlled study. We know the background of this study is that we know that 40% of treated hypertensive patients fail to achieve their blood pressure control, and that is despite the widespread availability of antihypertensive medication. And why is that? That is mainly because these patients are either not adherent to the medications, or they have intolerances to medications, or they are drug resistant. So we do need some good solutions for these patients. Currently, only proven solution is renal denervation. Now, renal denervation does help reduce blood pressures, but this is very expensive. It's invasive, and definitely it's not scalable. We cannot scale for millions and millions of such patients, so this technique is not possible for mass. Now, this technique does do one thing, which is called a neuromodulation. In this trial, SCRATCH-HTN, we have tried to find a neuromodulation study where we can do it in a low cost, in a non-invasive way, where patients self-administer this device, and that potentially can be scalable therapy. And that's why this is very innovative and therapy potentially to change the treatment horizon for these patients. So we in SCRATCH-HTN study, we had this device where patients self-administered stimulus in their tragus, both tragus, and they did for half an hour every day for first 14 days, and then once weekly in for the next 10 weeks. And this device, while they are stimulating them, they could read, they can do any work. So it was a kind of very easy for patients. They continue to take their antihypertensive medications, and these all patients were uncontrolled hypertensive patients. And we tested that with the sham device. Now, the sham device was similar, identical device, which was similar in all aspects, except it did not deliver this, current on the ears. That probably is also a slight limitation of this study, because current will be perceived by patients. So what we did try to mitigate this issue was by giving them a prescription of sub perception threshold current level, so they will not feel it. But one can argue that this perception level changes over a period of time, but we did try to maintain this blinding as much as possible. And this is what this study is about. This is a novel first in humans, I will say not man, but humans study, where we try to test this device. The reason why this is we think may work is the tragus is sensory innovation is through some sensory nerves and cranial nerve, which total recruit goes to a centrally nucleus tractus solitarius, where they could help improve vagal tone. So if you have an increased vagal dominance, most of these patients have a increased sympathetic overactivities, and a vagal dominance will naturally control that and hopefully reduce their blood pressures, and in addition to that may help with the sleep, well-being, and increase exercise. So this, in that way, this is an exciting solution with lots of potential. Our study was first in humans, so we were trying to learn about this technique and how we can help this improve blood pressures and other aspects of other diseases as well. So what we found is our study was basically found neutral results in whole cohort. So we didn't find at 3 months a difference between those who were allocated to active devices versus device which is sham device. However, there are nuances to it. We also predefined some populations where we looked at interactions, and we found that those with higher blood pressure when they were entered in the study had significantly more improvement with TAN device. So in those patients it did work. We also found then, because we anticipated that these issues will happen, because we could not do, because of the nature of device, a full blinding. What we found that we looked at the blinding index, and we found that despite our best efforts, we were only partially successful in blinding. We also measured their background medications. To show this device works, we hope that both in a sham arm and the active arm, the medications treatment background will be same. But what unfortunately we found that most of many of people in sham arm realize that they are in a sham arm, and they change their medications. So because of that, we could not find the clear differences. So this study, in addition that, we have data where we in a compliant patients who were compliant to this protocol. We had also, first 14 days they were taking the stimulation. We had the blood pressure at 14 days as well in those patients, and 1 month and 3 months. What we found that in these patients, after 14 days, there was a numerical difference in people who were active arm as compared to sham arm. So there was a 5 millimeter difference, which is, but it was not significant, mainly because of a power, because there were less number of patients on that one. And that difference reduced in 1 month and became neutral in 3 months. So that explains our overall results, because the potentially this stimulation should have been happening every day for 3 months, and we did it only for 2 weeks. So this study generated lots of much more important information which can change the horizon. It does shows now that it, while the results are largely neutral, those are mainly because of the reasons of changes in background medications, and also how the patient habit changed. Second, they likely are related to the stimulation frequency which we did. Potentially they would have been better with a better frequency and duration. Clearly documented that there is a subgroup which will benefit from it. So this trial, as first in human, generated lots of important information to take this science forward. So the drug, this device was very safe. So they were expected mild adverse effects with device. We knew that when the people will stimulate, they might feel a bit of pain and itchiness. That's what we got from our participants. But there was no serious adverse effects, no long-lasting serious effects or device effects. There was one serious adverse effect in sham arm patient developing atrial fibrillation, but nothing else. So it was quite safe. It was very acceptable. Patients liked it, and they used it every day. So we know this device can go to masses because it's safe, acceptable. As far as efficacy is concerned, I've already talked about efficacy, that there are signals that it may be efficacious, and we need a better study design to prove it further. I think obviously this is the early days with this device and technology. If we are able to do another study with a better study and show the efficacy, this potentially can change the horizon for most in this hypertension, and it will be a reasonably good option for people with medicine intolerances or issues with drug resistant patients. So this is potentially a solution for those patients. However, as I explained, we have not proven efficacy in this trial, but there are signals that there might be efficacy which we need to further investigate. It's a very loaded question. It's all the hypertension researchers like me are all working on this. So I will break on just let's talk about therapeutics, because measurements is a different ball game together. So I think it's a very exciting time for hypertension research. There are lots of new therapies being investigated: aldosterone synthase inhibitors, angiotensinogen blockers. They have been quite a good other potential medications in terms of endothelin receptor blockers as well. So there are several new therapies being investigated. I feel very much hopeful for aldosterone synthase inhibitors. I know there are trials have so far have given us mixed results, but these potentially can improve the care of a resistant hypertensive patient, because most of them will have hyperaldosteronism. Then it seems the research is also more forward, coming up with different technologies and different ways of antihypertensive agents. As I said, looking at angiotensinogen aspects, the injection which we have talked about, and those will be, if proven again, I know the results are mixed here. If proven, they will be, especially for people with the medicine intolerances, those injection may change. the horizon altogether. I think it's a excellent question. I think we should be treating our patients holistically. It's not one risk factor over above others. We know hypertension is predominant risk factors. It's one of the largest silent killer in the world, but it does mean that it's a bigger risk factor than, for example, obesity or hyperlipidemia or diabetes. So I think all risk factors should be treated equally to reduce the cardiovascular risk in total. So if my approach to my patients are, even if they come for their high elevated blood pressures, I look at their cholesterol, I look at their overall cardiovascular risk. If they're uncontrolled diabetic, I look at that. I look at their lipids, and I treat all of them, including the blood pressure. So you should not be focusing on one risk factors than others. Most of these resistant hypertensive patients, when we focus on their weight loss, we help them with overall risk. When we focus on their sleep apnea, we help them with the overall risk. So patients should be treated as a holistic thing rather than one risk factor